Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today's guest is someone who I'm guessing many of you either know or know of, and that's Dr. Maz Moshiri. Maz is an orthodontist, educator, and truly an all-around great guy. He received his BS in neurobiology from Emory University and went on to the University of Louisville, where he obtained his DDS, Master's in Oral Biology, and Certificate in Orthodontics. He practices with his dad and sister in Creve Coeur, Missouri, and he is truly a pioneer and expert in the area of clear aligner therapy. Many of you heard him lecture, including myself, but he's lectured nationally and internationally for align technology for over a decade now. And he's also the co-founder of the Aligner Intensive Fellowship, an online residency that has educated thousands of doctors worldwide on the proper treatment, planning, and use of clear aligners. In addition, Maz is a clinical assistant professor in the orthodontic residency program at St. Louis University, where he manages the clear aligner curriculum. During today's episode, Maz and I discuss his journey into the profession of orthodontics, the clinical academic divide and what can be done to help bridge that gap, the need to break free from the dogmas of our profession, the importance of persevering through life's very frequent challenges, how he became a pioneer in the area of clear aligner therapy, his vision for the profession to become less reactive and more proactive when it comes to patient care, the upcoming Winds of Change meeting in St. Louis that he is co-organizing, and much, much more. So without further ado, I am thrilled to bring you the amazing Dr. Maz Moshiri. Enjoy the show, everybody. So welcome to the Doc Podcast, Maz.
Thank you very much, Mike, for having me. I'm honored to be here.
Oh, the honor and pleasure are mine. I'm really excited to have you on and have this conversation with you. People know you and most in our profession know who you are if they don't know you personally, because you do make yourself amazingly available to people. Not only are you this big figure and large figure that's up on stage and teaching people and a leader in our profession, but you do make yourself very available to all of your colleagues. So most people know about you in some capacity, but I'd love to take the opportunity to let you dive a little deeper into that and tell the audience how you got here. I'm a big fan of people's journeys. I say all the time that people see where we are in life, and it's just human nature. We think like, oh, he's Dr. Maz. He's always been Dr. Maz. But before that, you were growing up in a dental family and having lots of thoughts about which direction to take in your career. So you can go back as far as you want to paint the picture for us and just take the floor and go through how you got to this point in your life.
Certainly not. The main influence for me, to be honest with you, and I know that this is probably a familiar story for you. Both my parents were dentists in some capacity. So my mom is an endodontist. My father is an orthodontist who still practices with me. My father was a substantial influence in my life in many positive ways. And so I would not be on this podcast if it were not for him. He is the main really impetus for me getting into orthodontics. Very, very hardworking immigrant, moved here from Iran, came here on a scholarship to go to Northwestern for orthodontics. And when he came to this country, the intention was to go back to Iran. However, the revolution broke out there and they replaced the Shah of Iran with Ayatollahs, and the whole country went into disarray. And his parents at the time, it's not a good place to come back to. So you just got to figure it out. And basically he had to go to dental school again to get credentialed, as did my mother. He ended up going to Washington University in St. Louis. And when he was in dental school at the age of 28, at the time, they then asked him to become the chairman of the ortho program.
Wow.
And so he was chairman of ortho, going through dental school to learn how to, or not to learn, but to rather to become an orthodontist accredited in the United States. And that planted us in St. Louis. And he did the academic stint with WashU for about 5 years before then retiring into a private practice setting. However, he did continue to teach, and he would go to the University of Louisville once a month for 30 years. And he did that He'd go on a Sunday, teach Monday, Tuesday, come back on a Tuesday night, and he would teach growth and development, orthodontic surgery, and TMD. And so that was really a substantial part of my influence is seeing him do that, seeing him
Mm.
try to teach, seeing him working in the office. And obviously, orthodontics is an 8 to 5 for the most part job. But as we all know, as small business owners, that's not really the case. You tend to bring things home with you per se. So he was working very hard growing up, and I saw that it influenced me very heavily. It's just what I thought or what was imprinted on me that I needed to do in terms of my present time and how to take care of my family. In addition to that, actually, this is a little bit odd, but he would go to Springfield, Missouri once a month as well. And that's Springfield, Missouri, relative to St. Louis, is about 3 hours away. He would go to Springfield on a Sunday night once a week, and he would practice there till Friday. So one whole week a month. And he also
Wow.
did that for 30 years. And he had
Oh
prac-
gosh.
yeah. So he had a separate practice there with a separate staff that he basically they worked 1 week a month. And issue was for him is that that office was producing as much in a week as St. Louis did in 3.
Wow.
And so it was very hard to let that go. But eventually, as I was able to grow the practice in St. Louis, I ended up selling that practice off, thankfully, because he did that
Okay.
years. He traveled twice a month for 30 years. And that was just, a lot for him to do. But just, he's a very hardworking, diligent. He's
Mm.
just, I have a lot of respect for him. And now that I'm in his shoes, people think I'm hardworking. My wife thinks I'm hardworking, but I don't think it holds the torch to what my dad did. So,
It's amazing. It's so fun to hear those stories because a lot of people have come before us, and as you alluded to, I come from a dental family, and my grandfather was an Italian immigrant who blazed a similar trail, and all four of his sons then went into the profession and became. My grandfather eventually became an oral surgeon and built a multidisciplinary, multi-specialty practice well in the 50s, well before that was in vogue and something that was happening. And then all four of his sons went and joined him in practice. 3 GPs, one oral surgeon. And now in the next generation, I became an orthodontist. And my two cousins, my one uncle's two boys, one is an endodontist outside of Boston, and the other is actually at Emory doing an oral surgery residency. So it's fascinating to hear how one person
mhm.
can start something like that and blaze a trail that then goes on for successive generations and gets passed down. And it's really neat to hear how they did it and did it in a way that led by example, and they just put their head down and and did what it took to and you obviously saw that in him. And the flip side of that though is, and I get asked this a lot, did you feel pressure to step into his shoes or to go in this direction that you have?
So it's interesting. The answer actually is no. But it's a roundabout way of saying no. I
Mhm.
was pressured into needing to do something that was in a higher academic caliber. And
Mm.
so my father was really just trying to urge me to become a doctor. I think that was the
Mm.
most important is that I want to become a doctor. So in that light, I did get into medical school out of high school. I
Okay.
got into an
Interesting.
accelerated 6-year program at UMKC, University of Missouri, Kansas City.
Interesting.
And I opted not to go into that,
Mm.
which really made him upset. And so we had a little bit of friction at that time in my life.
Mm.
The purpose of that for me was that I just really wanted to experience college. I wanted to have a 4-year experience of having a liberal arts education and just being able to experience life, but still having a focus. And I promised him that I still was going to focus on medicine. That's really what I really wanted to do, just simply from the fact that I actually love biology. I loved physiology. I loved anatomy. Those were the courses that interested me. I wasn't a mathematics guy. I didn't. I do like business. If I was to go to business school, I wouldn't mind that so much. But my passion was in biology. I found
Mm.
that, and so I ended up through that journey university, becoming disassociated with medicine a little bit from having shadowed one too many doctors.
Yep.
And so it made me reflect back on what my dad was doing. And it was like, you know what? I think I want to do orthodontics. And I think his whole impetus for doing that for whatever reason, um, to to not pull me into orthodontics was what he had structured for himself he was working so hard. I don't think he understood the opportunity of what he necessarily had for me to come in, being successful in life, because I don't think he approached it in the right way per se as an academic initially, but
Mhm.
not as a businessman or woman. And so the opportunity to come into orthodontics when I reflected on it, I thought was a medicine, but I also thought I had a journey I needed to undertake in terms of growing the business in St. Louis. I think he didn't want me to be separated like he was traveling all the time and doing those type of things in terms
Mhm.
of trying to keep that working. That's what his experience was. And he just thought that doctors were well off and could take care of their families and so on and so forth. He just wanted me to have a good life at the end of the day. Because that's the immigrant's journey. You want your kids to be better off than well, you had it. You want it to be a little bit easier for him, and that's what his perspective was. But I'm not necessarily sure that was true in hindsight. So I think it was a blessing that I found this profession the way I did.
Yeah, it's such a great example of how things do, I really believe, happen for a reason. And I say it all the time, but whatever people believe in is controlling us out there. You can call it what you want or label it what you want, but almost without fail, every guest I have on the show, there are these transition points in their life, and there are these landmark opportunities or disappointments or both that the ones who really reach the pinnacle persevere through. And I think the common thread is not only that there's something out there higher than us guiding us, beyond that, we have to the ones who get to that point just keep persevering. And as you said, it's that immigrant mentality. That was ingrained in me from the kid. Italian immigrants, they work hard. They all of them, they came over with nothing and built a life for themselves. They didn't expect handouts. They didn't want that. They wanted to build a better life for their families than they had. And that's the purpose of America. That's what this country is built on. And so it's interesting to hear those stories because we are all shaped by our experiences. We are all shaped by our upbringing, and we are all shaped by our successes and our failures. And here's a point at which you're disappointing your dad that you're looking to try to impress and embrace, and you're obviously very proud of what he's doing. And in doing that, it led you to a path that ended up putting you right by his side to help him out in a way that you probably wouldn't have been able to
Yeah,
had you gone on that path that you both thought was the path that you were going to go, right?
exactly. No, it was the biggest blessing for the mere fact also, not that I get to work with him now, but even when I was in dental school and eventually in residency, I went to University of Louisville. That's where he was teaching for 30 years. He would come in
Mm,
town once a month. We would go grab a nice dinner, and it was just like I got really close to him
mm.
then, full circle during that period of my time going through dentistry and orthodontics, and it just had something that we could also share in common, but being able to see him and have those memories with him was amazing, and now my sister is also an orthodontist and works with me as well, so it helped, I think, to shape her path as well in terms of me joining him in practice, so it's been a all-around blessing for sure.
No, it's absolutely awesome. And clearly now you all are making a big name for yourselves in the community with what you do for the community in your practice. And before we leave that, I want to just because your family, your dad, yourself, and I believe your sister as well, correct me if I'm wrong, are all involved in the academic side and the clinical side. You all are passionate about the teaching side. And it's something that I've been passionate about, and my family as well, all of them. My father is on his brothers, my uncles, my grandfather, all were passionate about both the clinical and the academic. I feel like in recent years, maybe decades, but there's been a gradual divide that's been widening between those two sides. And I feel like now it's almost instead of a symbiotic relationship, a nurturing relationship, it's become a bit adversarial, where you have academia over here saying we do it this way, and you have the clinicians over here saying no, but we can do it this way. People such as yourself are doing an amazing job trying to bridge that gap. That being said, it's still happening to the point that, and it's one of the saddest things I hear, but I hear it often. A lot of orthodontic residents with whom I speak, coach, teach, say they're just trying to get through their program to get their certificate, to get out there and learn how to do it in the real world.
Mhm.
I get there's always going to be some of that because a residency is insulated, it's different, it's never going to be the quote unquote real world. That being said, with all the time, energy, money, resources, dedication you put into these degrees, to have this feeling that you're just doing it to get a piece of paper so that you can go out and actually learn how to do it is really, really sad. So, do you see that? And if you do see that divide, how do we work to try to bridge that gap to get the clinical and the academic more on the same page?
It depends on, I think, the program. For example, I teach at St. Louis University. I think we're pretty blessed to have Dr. Kim as our chairman there because he is
Mhm.
really progressive and open-minded towards things. And so,
I've heard, by the way, nothing but good things about SLU from residents, faculty, other people, like literally echoed exactly what you just said.
yeah, he pretty much with proper precautions, we do, I think, introduce the residents to a lot of things that are used in private practice, such as shape memory aligners, 3D printing, robotically
Mhm,
wires for retainers, plenty of bariatric surgery cases that they can get with the oral surgeons there. They have a wide array of things I think they're able to do that they may not have the opportunity to do in other programs per se.
mhm,
But having said that, in teaching, I am confronted with dogma all the time.
mhm,
And so I think it's important that we as educators are able to, in a manner that is hopefully supported to some extent by data and research. I think that's the biggest divide is that people get so stuck in what the historic literature has presented, but yet literature may not have caught up to where we're at today.
mhm,
That's where you feel like you're pulling people into the 21st century with regards
mhm,
to what's happening. But those individuals that are stuck in dogma say, well, it hasn't been proven yet in research, or, the research doesn't support this conclusion yet. But research can also be extremely biased. And,
mhm. Yes, it can.
so it's a matter of trying to, in an educated manner that's in the best interest of the patient at the end of the day, be able to present them clinically with what you're doing and showing them the results, right? So when I
Mhm,
go in there and I teach, I don't have all this data to show what I'm doing with Invisalign, for example, or how to make Invisalign proficient. I just have 20 years of experience of doing it,
mhm,
right?
mhm,
And so it's a matter of just them lending on my experience to do so. And if they want to do research, they're welcome to mine my data to do research. I'm happy to
mhm,
support trying to put research out there, which we've been trying to do. You're running a full-time practice, you have a family at home, you're teaching. There's only so much bandwidth also to support doing these ancillary projects, which again, I do my best to try to do like one a paper a year, two papers a year, provide data to do those things. And so I think over time, hopefully what they're looking for in terms of the data will be there. But in the meantime, it's a matter of just establishing, I think, trust and rapport and try to pragmatically teach residents what we see on a daily basis. And it's just giving your time. I think if you're not willing to go, and I know you go to universities, but we as private practitioners need to be willing to also go to universities because
mhm,
if you're just depending on the full-time faculty, and this is not a knock against full-time faculty, but full-time faculty have a responsibility to teach the foundations of orthodontics.
mhm,
They then lack private practice experience, many of them.
mhm.
And so that's a huge gap to try to bridge. And so that bridge needs to come from, I think, part-time faculty who are in full-time practice that need to give their time and try to draw correlations, yet not have lines in the sand with regards to what's being taught in schools, because those guardrails, I think, are important enough to be dangerous when you come out of residency.
Mhm.
A lot of what's taught is to hopefully keep people in their respective lanes, but you don't grow or you don't learn if you get uncomfortable either and try to get outside of those lanes. And so that's where I think having the vision of what a private practitioner can offer, I think is important. But the the question is very tough to answer, Mike. I'm hopefully answering, but also dancing around it because I honestly don't know what the answer may be as a concrete answer. I think it's just more education, honestly, and just trying to hopefully have rapport with your residents and having them see what the future is through your practice. People come by my practice all the time. The residents, my door is open to them. And so
Mhm.
I think that's really the best experience for them is, and I want them to ask questions because at the end of the day, if they don't ask questions, they need to come up with their own conclusions as well. I've sat in lectures before where I've heard someone give an answer. I'm like, that's BS, right? You need to be able to question things and discern the answer for yourself, but back it up with what you've learned.
I love that answer. I really, I mean that because it's not a simple question. It's not a simple problem. It's multifaceted and it requires everything you just said. It requires the establishment being willing to set aside some of their dogmatism. It requires the clinicians and the private practitioners to maybe be a little more generous with their time and knowledge and get into some of these training programs because that duality of traditional academia and people out there in the front lines pushing the envelope are really what advance our profession. And I feel like if you look back at the literature, we saw much more of that in the 70s and the 80s, maybe into the 90s. And I feel like in the last 20 to 30 years, we don't see as many studies coming out with this conjoined effort between a private practitioner and a residency. We used to see a lot of these. McNamara used to do a lot of studies involving private practitioners and outside of where the university was in Michigan, and in Iowa we saw that, and we would see a lot of the at UConn where I went, we had that. So you'd see this combined effort. I feel like now, just pick up any of our AJODO journals, and you will barely see a lot of research coming out of the US. I mean, all these residents are doing all these master's research projects, but where are the big publications coming out of our US ortho programs? I'm not saying there shouldn't be an international contribution to this. I'm just saying we need to do our part. And I feel like a big struggle in that is they don't have the data, because the resident is there for a shorter period of time. If they're going to do a randomized control trial, a prospective study looking at the treatment of X number of patients, that resident's probably only starting 50 cases total. How many of that resident's cases are really going to apply to that subset of what they're trying to study?
Yeah.
That's why a lot of them end up doing some lab stuff, some bench work stuff. And I'm not minimizing that. It's just looking at clinical research in these orthodontic residency programs is really tough, because if you want to eliminate your biases and have operator standardization, you can take it across 15 residents in the program and take all their different cases. And well, now you've got a lack of interoperator reliability. And so it becomes a challenge. And that's where I feel when I'm actually working on ANOVA, I'm sharing, as much as you said, I'm sharing my data, almost 10 years of pre and post cone beams on a lot of these patients I've done phase 1 on, and early arch development and expansion and airway, impacting the airway. We're starting to look at that data because it's me as the only clinician that ever treated these patients. It's standardized protocols, and I can lend them my data. Yes, it's retrospective. That being said, we can at least start to put some numbers behind this to say, this is what's happening. And I'd love that you're contributing to that as well. And I feel more clinicians do need to do that. I feel like in the clinical side, we're often so quick to say it's academia, and yeah, there's some problems there. We need to get more institutions doing what you were describing is happening in St. Louis. That being said, the private practitioners in the area around these institutions need to step up and contribute and be there and teach, even doing 1 day a month. I mean, the residents just soak up the information from people who are doing this out in this quote unquote real world or out in private practice. Another thing you alluded to, which I love, is change comes from the fringe. I've said often the Peter Attia concept of evidence informed versus evidence based. Evidence informed is how a lot of our medicine progresses, right? We make something in a lab, or we do something, or a pharmaceutical company designs a drug or whatever it is. And even if it goes through all these trials, we don't really understand what's going to happen with it until it's out there in the field. I mean, that's
No.
why a lot of our medicine advanced after world wars, because we had to try things that you didn't have a choice. And then you learn from that. And so when you're pushed to those limits, which you are in private practice every day, you have to figure out other ways to do things. So I love that part of it as well. And as far as the overall mission going forward, what would be your message to the profession? Because I do feel like there are a lot of places where the traditional dogmatic philosophy is pervasive, and they're not as open to other ideas in terms of residency training programs. Can you offer any pearls to those programs to say, here are some things you could do to get your residents a little more prepared to be practicing in the way that you or I might be practicing out in private practice? Because I'll just preface that too by saying there's a lot of residencies where if a resident's 1 or 2 clear aligner cases, their whole 3 years there, that's not abnormal. If a resident treats 1 or 2 phase 1 cases or none, their whole time there, that's not abnormal. And so how do we start to get that fixed?
Yeah, I think the first and foremost, you're talking about, I think, two different topics here. One is it's referring to diagnosis, appropriate diagnosis for patients, and being open-minded to that, because many
Mhm.
programs may not even get a phase 1 type of education period. And then
Yes.
the resident comes out, and all of a sudden they see all these kids in their practice, and AOs telling them to maybe monitor them around age 7, but they may be able to treat them even before that for certain problems and have really good outcomes for that kiddo, and actually
Mhm.
do what's in the best interest of the patient. So that's one variable. The other variable is, I think I truly believe this. This is obviously a opinionated statement, but I think the future of orthodontics is digital.
Mhm.
And so if they're not getting education in digital, you're not setting that doctor up for success. The foundation of anything orthodontically is diagnosis, but then how you apply that diagnosis then we'll go through your treatment mechanics for that patient. And having a digital practice will eventually allow you to not only service your patients in a more efficient manner, and to provide them with customized appliances, for example. And just one example of that would be, we used to place separators and band all of our appliances and then take an impression and send them to a lab, blah, 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 blah. Now we scan them and just deliver the appliance. It's a much better fitting appliance. What's in the best
Mhm.
interest of the patient? Having that actual workflow in your practice, right? There's no detriment to that. That's only in the benefit of the patient, but you have to have a digital workflow to facilitate that. That's one example. I can give you 3 or 4 more. Or integrating CBCT into your diagnosis and being able to
Mhm.
actually understand what you're seeing and what's available with that, with, again, with light force, for example, or Invisalign having the roots in the alveolus. So you
Mhm.
can see what's happening, because before, was it a failure of the aligner to move the tooth, or were you running the root into the cortical plate and you didn't know
Mhm.
the plate was there?
Mhm.
So just having all those things to help your patient out, but also have you be more efficient, which allows then the profession, and this, you can take this for what it's worth, but allows you to see more patients potentially
Mhm.
in less time when we're trying to protect our profession, right? And to do what's in the best interest of our patients. That sets the individual up for success long term, to be able to provide equal, if not better result, less visits, less time, being able to run an efficient and effective practice for your
Mhm.
patient. I think those are all the things that need to be focused on in residency, but I know to do that at scale is probably very challenging to do
Mhm.
that in residency, but at least introducing the idea, allowing them to dabble, allowing them to learn on all those types of tools are very important. And having people, I think it's so important to have. I remember I can't remember this guy's name, but I think he practiced in Florida. And I think the last name was Alpern or Alpert, but he wrote several books. End of the day,
Alpern. Yeah.
Alfred, he was
Yeah.
very controversial, like, at the time. I remember he used to wear, like, he had his patients wear headgear off of a football helmet or something. Like, it was something
Mhm. Mhm.
crazy.
That
Like, I
sounds
remember
familiar. Yeah. Yeah.
all these different things that were just like, you hear it and it was so controversial. But it's so important to hear that. It's so important to be exposed to that. That controversy is very important. You shouldn't hide that controversy away from people, because you have to
Mhm.
have healthy debate. You have to have healthy discussions. That allows for progress. For example, I was at the AO recently. This was last year in May or in April, whenever it was. And I heard Hugo de Klerk speak, and I'm used to him speaking on his bollard plates with regards to class 3 correction,
Mhm.
which I remember the first time he had presented that 10, 15 years ago, it was very eye-opening for me. He was showing literature with CBCT with Sevedenus, showing temporomandibular fossa remodeling and redirection of growth from
Mhm.
just using the light elastics on a 24-hour basis, whereas we were used to, as a profession, wearing them orthopedically at nighttime only off of a face mask, right? So just a
Mhm.
progress and trend in how you would treat that type of malocclusion. It was just different from anything we'd done before. And also getting change in adolescence, which we've been taught to do that in a pre-adolescent phase to be successful. So just expanding the window of what's possible for the profession.
Mhm.
Well, he was speaking on class 2 malocclusions a bit ago, and he made the statement, which is ingrained in our profession. A lot of the class 2 literature was done incorrectly, and that the data was not very sound by present day standards. Basically arguing that functional appliances can be effective for growth modification to grow a mandible. Now, that's a very contentious statement to say, right?
Right.
And if you're going to ask me where my mind is on it, I'm still learning. My mind isn't made up, but I'm open minded to learning about it. And what he was saying was that when you have functional appliances, and the lower incisors hit the back of the upper incisors, it limits the actual progress you can get for what
Mhm.
you're trying to do for orthopedically modifying that mandible. So he
Mhm.
was running his elastics off of the bone plates again. So he had skeletal anchored functional appliances, and he had, I think it was like a Forceps or a Herps type appliance off the bone plates, which is a lot of mechanics, right? You're talking about, that's a lot to go through to put in a kid's mouth. But he was showing just really amazing changes orthopedically for these kiddos. Now, the dogmatic person is going to say, well, how do you know that's true actual growth modification? That probably is inherent in that kid's genetics.
Right. Right.
Okay, but what if you did
Yeah.
nothing, right? What if that kid would had their mandible trapped and you didn't actually open them up and allow them to grow, right,
Right.
in the manner of what he's showing? Like, could you be expressing those genetics potentially? Yes, you could, but could you also
Mhm.
be enhancing those genetics? You probably could as well, right? So which side of the coin is my mind on yet? It's just a matter of being open minded. I'm not stuck in, like, no, you only give that kid a reverse pull or a normal cervical headgear because it's a maxillary problem. It's not a mandibular problem, right?
Yeah.
Just like it's just you have to be open minded to just being plastic with your brain, have plasticity to it. I take in things. I'm open minded. I'm very blessed that my dad taught me that. My dad was always very open-minded to things, to do things in a
Mm.
manner that would help to facilitate growth. We tried things. He never limited my learning curve in practice. I wanted to try Invisalign. We hadn't done one Invisalign case. He's like, that's your baby. You run with it. You do whatever you want." But to have that sense of confidence for me that I had him behind me was huge because I knew that he could basically cover up any of the mistakes I would make. Just
Mhm.
having that as a background. So, but yeah, just being open-minded, I think is huge, Mike. It's very important that we are always learning, that we're constantly learning. You don't stop learning is the most important.
It's so well said. There's so many pearls in what you just said there. I hope people literally go back and listen to that again because you do a really nice job, which is why you're such a good teacher, in breaking down complex things into their subparts and explaining them in a way that people can understand. And one of the things you touched on, diagnosis, right? All the technology, everything we're looking at, yes, that's going to increase and improve our delivery. And obviously, there's AI and other things that will help us increase our diagnostics, but you can't get away from the diagnostics. And I feel like one of the things that happens is people jump to the treatment so quickly and they get caught in this pattern and, for lack of a better word, regimented routine that they can't break free from. And they put those blinders on because you mentioned it. The thought of just going through what the clerk was talking about and putting these plates in and changing your systems. You're like, no, I give this kid a headgear at 10 and it works in my practice. And I'm just going to be dogmatic and say that's it. So the change isn't easy for people, especially the longer you've been doing it. That being said, too, to be open minded, I give your dad tremendous credit. And clearly, that's another common theme I see amongst people with whom I speak, the open-mindedness, the importance of diagnostics, remaining open-minded, and then the other part which you alluded to was looking at what you're doing and paying attention to what you're doing and looking at the results that you're getting or not getting. Because if you just do it blindly and you convince yourself it's fine, that's obviously not going to achieve much. You also can't be a cowboy and just go in and just start doing all these crazy things because you are accountable to your patients. You have liability and there's ethics, and you don't want to just be trying all these things. So tying that into how you push the envelope with aligners, that actually is really interesting too, that you had your dad there to be able to insulate you a little bit. Not that it's not still tremendously impressive what you did to push that envelope and be truly a real visionary in the aligner arena. It's interesting though, you had a little bit of that safety net to allow you, sounds like, to push that envelope a little more aggressively than maybe you would have if you were on your own. But the thing is, for people out there listening, not everyone has to be a Dr. Maz and go out there and push it to that extent. You just have to then, when you have people such as yourself doing it, be more open-minded to looking at what you're doing and saying, maybe I could incorporate some of that into my practice. Would you agree with that?
100%. I had some false confidence to kind of outside of the box in terms of what maybe aligners were prescribed to do back in the day. We were treating more exotic type of cases or just trying to do things that people said weren't possible with it. And I knew that I could always recover from that, meaning that
Mm,
go to braces and just do what I need to do. And I had a very experienced practitioner standing over my shoulder, which
mm,
was huge for me. But what I've see happen, which I think is what you're getting at, is that doctors may get out and they're overwhelmed with many things. Obviously, there's a lot of different things that fly at them to learn about, but they stop actually learning orthodontics. They start trying to learn how to run a practice, but they stop learning orthodontics. And you
mm,
can't do that. Like, you're at the beginning of a whole new journey when you get out of school. And yes, you need to learn how to run a practice, manage your assistants, manage your time in the consult room, have efficient treatment mechanics. But you start losing diagnosis over time with that until you make a mistake. I think we
mm,
get that diagnosis through making mistakes over time, but we don't continue to push to actually learn more outside of that. Like, I remember I got out and I read Prophet like three more times on my own. Like, that was my nightly.
mhm,
Like, I read Prophet
mhm,
again. I read Graeber again. I was trying to buy as many orthodontic books as possible to continue to learn orthodontics, even though I had my dad, who was a chairman of the program and a teacher for 30 years there. We were always sharing AJO articles with each other, highlighting things. We were going to AO hip to hip. We were nonstop learning orthodontics. And it's just important that you continue on that path, that journey, because as we mentioned before, you may not get enough in residency. You get enough in residency to get your degree, but that doesn't make you an orthodontist. Like that, you still need a lot more education and training to actually get to where you want to be as a clinician. I remember, Mike, I had a man crush on Anoop Sandhi.
Yeah, Manoop had the in-office course, right? And he was
Yes.
big on pre-pasting brackets and indirect bonding, right? Back in the late 90s, early 2000s.
Yeah. So I went to that course 3 times
Okay.
just because I was just infatuated with not only his office at the time, I loved how his office was running. So I wanted to learn as much from him as possible. But I also thought he was an amazing diagnostician and clinician. I couldn't get enough information from him. And I remember I was at his in-office course, and he must have been in his late 60s at the time. And I said, Dr. Sandhi, when do you think you're going to slow down? When are you going to retire? I remember he looked at me, he was like, Maz, why the hell would I retire? I just figured out what I'm doing. And for him to say that to me, I was just in awe. I was like, wow. But that spoke a lot to me. I'll never forget that, obviously, is
Mm.
that it's a constant learning process and you're constantly fine tuning things. I'm constantly learning, but it's not from just being in my office. I'm always trying to expand my horizons, listen to podcasts such as yours, read materials, and just try to gather as much information as possible. So,
That lifelong learning is so key and so pivotal. And before we leave it, I want to touch on, because I don't want to gloss over to minimize it, um, how much you push the envelope with clear aligners and how much, I'm not saying this in a patronizing way, how much clear aligner industry would not be where it is today if you weren't part of it. I'm dead serious in that. And I
right.
say that, I can speak personally because you came up to Albany, New York, where I was practicing back then in a different life. And that was probably about 10 years ago in the mid teens. And Paul Seraphin was our rep up there.
Yeah.
And Paul got some great speakers to come up. And he had you and he reached out to me and he's like, you got to come see this guy. And you were just starting in your journey to be educating people in aligners. And you opened my eyes to things that I was a big skeptic of it. I believed in the possibility of clear aligner therapy, but for the people who are newer practicing or haven't been around for as long, as recently as 10 years ago, we didn't think as a profession that plastic could do much more than straighten some teeth around or tip some teeth around. It was about 10 years ago, and you correct me if I'm wrong on that timeline, but in my recollection, that we started to really realize, like, hey, wait, there are people out there doing things with plastic that we didn't think were possible. To part of our earlier conversation, again, it was before any studies were done or research. We were pushing the envelope clinically, making evidence-informed decisions. We knew the biology of tooth movement. We knew how teeth moved and the force magnitudes therein. We just didn't know how to do it with plastic versus metal. And you really pushed that envelope. And after seeing you come and give that, it was a small room, maybe 15, 20 of us there. It changed my entire outlook on aligners. And I had this attitude of, well, wow, if he can do it, I just have to learn the skill set. And when I teach the residents today, I reference what I learned from you back then. Having enough clearance of overjet was a huge part. And over opening the bite. And these are all things that a lot of people now, it's just commonplace, but you were saying this stuff 10 years ago. So I want to make sure I give you credit for that because you're very humble and you would never go say that on your own. But you have done a tremendous amount to advance this. Plus, with your Aligner Institute, with Jonathan, what you guys have done. So talk to me a little bit about that journey. How did you go from just saying, hey, I'm going to try some more of this stuff and having your dad there to support you in that to really becoming a key figure in the aligner arena?
So I appreciate your compliments. Thank you for that. If I go back, I guess 15 years, and I was really trying to learn clear aligners, I first of all have to give some credit to 2 people, which is David Boschkin, who's an orthodontist out of San Francisco, and Dan Gurman, who is now since retired out of private practice. But basically 2 orthodontists that I met at the same evening. And it was 2007, and I had just taken my Part 1 ABO boards. I had zero Invisalign really experience or curriculum outside of a part-time teacher named Dr. Perlmutter in Louisville who gave some lectures, but I was yearning for more, just to feel like I had gotten more education and out of residency. So I drove to Lexington, Kentucky, about an hour and a half away, and went to a study club, which David Boschkin was speaking. And he really was showing cases that were just mind blowing to me. completely outside of the box of what we were being told could be done in residency. And then when I was there, Dan Gurman, who was one of my dad's residents, he had been in private practice in Dayton, Ohio, and he had driven from Dayton, Ohio to Lexington, Kentucky to go to the study
Uh,
club. Okay. So I saw this guy who had a very successful practice in Dayton. He was seeing over 100 patients a day and just he had built a really nice practice. He said, Maz, come visit me. I remember his words were, I feel like I owe it to your father for you to come visit me. And so I was like, I'm going to take you up on that. And so I went and visited him for 2 days. And as I mentioned, he was seeing over 100 patients a day, but at that time in 2007, over half of them were in Invisalign.
That's
And
that's
so,
unbelievable for people out there who
yeah,
who were in practice in 2007. That's unbelievable.
yes, it was a complete eye-opening experience for me. And he was the largest Invisalign team provider at the time in the United States as well. And, but it was like a humble brag, meaning that like you wouldn't know it. He wasn't advertising that way. He wasn't speaking. He was just doing. And so I went there and he's like, you can shadow me. You can glove up for any patient, take a look, and any questions you have, let me know. And so I was going around shadowing him, going into consult, seeing all the patients with them. And then I was looking at the case types and I'm like, these must all just be like class one crowding cases. He had TADs there. He was doing orthosurgery cases. He was doing extraction cases. Yeah.
Wow.
I was just, my mind was blown.
What a visionary. Amazing.
Extreme visionary. And so at that point in time, when I came back to St. Louis, I said, this is my mission because if he did this in Dayton, Ohio, I need to learn how to do this. He's much like you. If I'm sitting in the audience and I see someone doing something spectacular, I don't sit there and look at them and say, oh, I can never do that. It's like, how am I going to do that?
Yeah.
How am I going to figure that out? How am I going to do that? So at that point forward, I just devoted myself to learning about it. The interesting thing in my practice though, is that when my father's practice is a very niche practice in St. Louis. We had about 50% adults
Mm.
and not too many kids. And the reason why we had too many adults is that he was one of the only people in St. Louis treating TMD.
Okay.
And so a lot of these patients we would treat with splint therapy and physical therapy first, have them become asymptomatic to see if we could facilitate any bite correction for them orthodontic if it was justified for them.
Mhm.
And so a lot of those patients, if we were transitioning them to orthodontics, we did embraces, obviously. And the majority of these patients are usually female and adult. And
Mhm.
so we started getting more and more questions of, can you do this with Invisalign?
Mm.
And so we went on that journey of trying to do this with Invisalign for them. We had a lot of failures in the beginning of just ignorance of not knowing what to do and how to do it. But over time, I realized that a lot of the failures were coming from heavy anterior centric contacts. So
Mhm.
honestly, I started just exaggerating it in the clinch.
Mhm.
So you know what? This is a problem. So this is how I'm going to fix it. And
Mhm.
then lo and behold, full circle to your initial question, we started finishing our cases much better. And so then I was sitting in the audience at these lectures because I'm still learning, obviously. And I hear a lot of practitioners saying posterior open bites are because of the presence of the plastic. So just eventually cut the aligners and you're going to settle.
Mhm.
And I'm sitting in the audience, I'm thinking, well, if they would have anterior centric contact that's distalizing the mandible, putting into a worse position of the fossa, and then you're going to settle the occlusion there.
Mhm.
That's what they're saying.
Yeah.
So I'm like, I need to speak up about this because I think that they're teaching the wrong thing.
Mhm.
That's where that all started was I spoke to my rep and I said, this is not correct. Like what I'm hearing over and over again, this is not correct. This is what I'm seeing. And they said, well, do you want to speak on it? Do you want to just give a talk on it? And so I said, yeah, I'd love to give a talk on it. And I spoke at the 2013 AO in Philly for the first time. It was a booth presentation about my first opportunity to speak. And then the people that were at that time at head of education in a line heard me talk and they said, you know what, we would like you to lecture more. And that kind of began that journey of where I'm at today, speaking more and more and more on topics that my impetus for doing this was not to become a speaker for Invisalign. It was to
Mm.
help doctors do better with clear aligners. But I think the message hit home well with people because I always try to translate the teachings with what we do in fixed
Yeah.
because it's,
And
we're
that was very helpful that you did an amazing job of that. Just so you know, that was a big light switch for me when you got my mind to switch to say, just think of this as moving teeth, just using a different material,
yeah,
not a totally different fundamental philosophy from what you were trained on.
yes. I appreciate that. And yeah, it just seemed to stick and it just continue to gain momentum. So then in speaking with Invisalign, one meeting I met Jonathan Nicodemus. And to give Jonathan credit, I had also read some of his articles back in the day, which were like in
Mhm.
JCO Orthodontic Products, and he was just putting out pearls on
Mhm.
how, rotate laterals or whatever the case may be. And so when I met him, we struck up a friendship, and through our friendship, we realized that there was a lack of formal education for clear
Mhm.
aligners. It was all going to study club meetings at a restaurant. Maybe you went to the summit. Maybe there was a regional meeting, but there wasn't really a formal book or anything like that to go through A to Z. How do you treat with clear aligners in orthodontics? How
Mhm.
does a
Right.
resident learn to do this? There was nothing.
Right.
And so we met and we ideated out a textbook. And we presented this textbook to Align, and they wanted nothing to do with it.
Hmm.
And so, because we didn't know how to publish a textbook, um, so we put our tail between our legs and went back home. And we sat on the idea for a while. And in that time, while we were sitting on the idea, I was part of a Facebook group called the Orthodontic Exchange. It was probably the first orthodontic Facebook group ran by David Butler, who was a
Mm.
gentleman who went to Louisville, who I knew him through residency. And eventually, this Facebook group grew into a geographic exclusivity type of group where he started
Mhm.
monetizing it as well, so you could be a part of it, which still had a lot of value to it in terms of the ideas you were getting from marketing or how to run your business and so forth. And my wife sees me spending all this time on Facebook. She's like, "What are you doing?" Like, she's like, "You have a life. Like, why are you on Facebook so much?" I was like, "Well, I'm actually learning. I'm on this, like, just reading these threads. Like, it's really very beneficial for my practice." And she said, "Well, why don't you put your course online if that's effective?" Right? And I looked at her, and a light bulb just went off.
Mhm.
And I immediately called Jonathan. I said, "Jonathan, this is what we're doing." And Mike, I'm not kidding you. The next day, he and I were recording all of our PowerPoints in the format of the textbook we had already outlined years before, and just put this out there as a course. And the first fellowship we launched sold out because we didn't know what with we, um, you know, what we could handle in terms of being able to do it in the right way to service questions.
Sure.
So we capped it at like 100 doctors, but we had a waiting list of like 300 after that. And we're still recording the content while the course had started because we just knew we had to get this out there. And it just continued to evolve and morph and be refined, detailed, and it became a business of its own, which is
Mm.
interesting to have a full-time profession and have another full-time job when you come home. My wife was extremely helpful in the beginning in terms of managing everything. I would not have been able to do it without her. But eventually now we have a team of 4 people who run that
Mm.
business on the back end. And we've trained 6,000 orthodontists worldwide, and that
Wow.
we've kept it orthodontic exclusive as a way to honor our profession. Honest, I'm not saying this in a way to brag, but I'm trying to be realistic about it. We could have made a lot of money by putting this out to dentists, a lot of,
Mhm. That's true. Yep.
and we have not. And the reason why we don't do that is because we really respect our profession, and I want us to be the harbingers of that type of care for
Mhm.
people when they need clear aligner treatment. We need to be the ones to be delivering it, and I think that's one of the knocks that our profession has against Invisalign is that they introduced the concept of clear aligners in that obviously dentists can do clear aligners. And I think that's always going to be something that we hold a grudge to. And so we're trying to hopefully provide us more power to hopefully get that back.
Yeah, a lot of themes there. Just going to touch on a few that pearls, which and you offer so many of, is remaining open minded and never stopping learning. That constant desire to learn and push. You're in with your dad. You could have just been like, I'm just going to learn from my dad and do what he did. He's been very successful. You didn't have to go traveling up and listen to Dr. Spashkin and German and figuring out this whole new way to practice. You didn't have to then listen to it and implement it. You push to then lecture and speak up. And so having the courage to speak up for what you're seeing and what you're believing in, and then being persistent. That is another common thread I see in people who are able to really have a profound impact on their career, their family, whatever it might be, is their persistence. You had so many roadblocks, and I really appreciate you going into detail on that because so many people, as I alluded to before, see Dr. Maz of today, and it's just human nature to be like, oh, well, it comes easy to him, or he just understands plastic. He always has. I can never achieve that. And while they may never achieve it at the level you have because you have all this experience and knowledge base. They can learn from you and keep an open mind. And I think it's really important they recognize you didn't just wake up one day and figure out how to do this. This has been over a decade, and we're heading on towards 20 years here of your journey. So a message to everyone out there, these common themes of persistence, sticking it through when you get the door slammed in your face. Most people probably don't know that at one point Invisalign or line was like, no thanks. You guys could have just said, we'll just keep it between ourselves, do what we're doing in our own practice. But you had a mission and a vision to teach at a higher level and educate our colleagues. And it's totally changed the profession, Maz. I'm not overstating that. It really has. And the other interesting thing is when you said your wife got that light bulb on. I always joke with my wife and say, yeah, I'm so glad I had the idea in a podcast. But I was having about a year and a half ago, I was building all this new content and going in this new path of educating and just thinking, like, how do I get it out there? And she was watching me spend countless hours building these CE courses and on the computer and generating all this content. And she's like, I'm just like, I don't, marketing is not my strength. Promo is not my strength. And so I was like, I just don't know how to get it out there. And she said, you should podcast. And I was like, podcast? I don't know doing podcasting. Like, I've listened to a few, but I have no idea. And sometimes it takes that light bulb from the people who know us best. We tend to be so driven and focused, and I'll just keep, digging that trench to get to where I want to go and not realize there's something easier to do it with. And I was like, oh, well, let me look into it. And that's how that started. So I wouldn't be talking to you today, just as you wouldn't be in that capacity if it weren't for our spouses in our cases, but in other people's lives, even if you don't have a spouse, just there's people out there that I believe are messengers, that are little signs that are just going to help you think differently. And our job is to remain open-minded enough to just not close that door. And I think that's a big part of Invisalign for people. And also back to what we started talking about with academia, right? And the dogmatism. It just be open-minded to some of these things. And if you don't want to do it, that's okay. Maybe it's not for you. Maybe you don't have an interest in treating with plastic or phase one or whatever it is. Where I start to get frustrated is when you see people that just say it's not possible or no one should be doing it or it's not the case. And you've clearly broken down those barriers. And I want to acknowledge that because people today just think of aligners as just a part of practice. But as recently as I said, 10 years ago, that wasn't the case. It was a small segment.
Yeah, for sure. No, it's come a long way. And I think just, with anything, experience, practice, knowing how to use it better has given people more confidence to integrate it. Because I can respect that people want to do what's in the best interest of their patients. So they didn't have confidence they would perform the same way as braces.
Mm.
But there was a lack of understanding that was not allowing that to happen. So I don't like when people say can't do something when they don't
Mm.
truly know that. They're just saying it because that's what the literature says. But that literature, in my opinion, on plastic to this extent has many flaws in it. And I will go to the extent of saying it's incorrect. And so does plastic have its inefficiencies? Does it have its negatives? 100% it does, but so do braces. And so
Mhm.
we have to just understand those analogies between them and how to enhance the treatment mechanics to make them work for your patients. So we've serviced and helped a lot of people's lives with clear
Yes.
aligners. I'll never stop using it. I'm continuously learning how to use it more. Because so this is another strange fact that many people may not know is that if you look at the percentage of my practice, we're 50% clear aligners and we're 50% fixed appliances.
Mhm.
And so I'm not an Invisalignist by any means.
Mhm.
We treat a lot of patients with Invisalign, but it doesn't go in everyone's mouth. Now, having said that, I feel like my next journey is going to be how to learn better to use clear aligners in patients that need phase one. Because
Mhm.
historically, I've not been doing that. I've been using a lot of just traditional Haas expanders, for example, maybe doing 2x4s on the lower arch or holding arches and not developing the lower arch enough. And so I think that's been a deficiency of mine is putting in holding arches, not actually developing the lower arch.
Mhm.
I think
Mhm.
a liner may be the best tool to do that. Because if you think about what a clear liner is, you have control of that whole lower arch form and you can
Mhm.
select the open space where you lost space. I think that's the next paradigm shift in orthodontics is using clear liners in phase one. And I went to the Invisalign Summit recently and I saw some very intriguing lectures that I was just typically kidding with my dad about. And there were some doctors that were doing, there's one doctor that did like 2,000 phase one cases with Invisalign first. And I think the knock on that always is like, well, the kid's not going to wear it, but that's not really true because again, that's just, I don't want to say that's dogma, but that's just being stuck in your own beliefs.
Yep.
Those kids are usually the most compliant, that age group. The adolescents, you may tend to lose them a little more.
Hmm.
And then the other part of that for us was that thinking through it, why let the malocclusion develop if you can actually intercept it and allow for proper arch development and guide the teeth in the right position? What's more stable when the periodontal ligaments haven't fully formed and the apexes are still open? You're actually letting the teeth come into the right spot and not ignoring also the etiology of that malocclusion, right? If they have low tongue posture or other type of issues, looking at it comprehensively, well, does that shift the paradigm in orthodontics to do that at a younger age for the kiddo? And then when they actually get to that age 11, 12, you have nothing to do. You maybe have a little bit of cleanup. We don't have the data on that. We don't have the understanding of that. I think we
I'm working on it, by the way, with not with the liners, but I'm working on exactly what you just said. We've
I
never
think our
spoken about this. You and I have
or
never talked about this. And I
no,
say I promote and teach exactly what you're saying. I choose to do it with fixed appliances. Again, to me, it's just like with comprehensive treatment. Some people are more comfortable with one over the other. There were reasons why I preferred it with fixed appliances. So also, when I started doing it, Invisalign First wasn't a thing. So I developed a lot of great systems to make this very easy and effective. But the concept is the same. And I have people I coach and teach who use Invisalign First for it, and they love it and prefer that to braces. And I have people who prefer the braces. The compliance, you're 110% right. Because after I did my phase one, which was basically comprehensive in nature in the sense that I was moving all the teeth. I was using and teach upper and lower full braces. You goes beyond talking about this today, but there's a lot of data and literature out there going back to Ricketts in the 60s and 70s with the light forces and Melson looking at the suture anatomy in her article from 75 on these younger patients. And we can get in a whole debate over whether how much force you need for the different types of expansion. The point is light forces, at least, even if you go 400 grams as light with 453 grams being a pound, so less than a pound, we've known for decades is enough to get orthopedic change in young patients.
right.
And you combine that with the mandibular arch and the dental alveolar change, which the literature has so much evidence of us going back. Schwartz and Gratzinger were talking about expanding the lower arch in the 60s. So this is not new. McNamara has done multiple studies on this to show that you have to address that. Ilya Lipkin on recently on the podcast, and he was talking about that he uses the mandible as his template and puts the teeth over that bone, which is what I do. So what you're saying, I absolutely love. And it's so interesting because I feel that is the next paradigm shift in our profession. So I'm glad to see we have some others that can join this fight. We'll get to the winds of change in a moment, and I'll be talking about this in one capacity there as well. But the point is that when you go in young on these kids, and young, some people are going in 3, 4, 5, and that was outside of my wheelhouse because I wasn't seeing patients at that age, but I certainly have no problem with it. And I think clear aligners could be a really nice adjunct at that point because putting full braces on a 4-year-old has a lot of other logistical issues. But when you get them in the early mixed dentition and you put them in full fixed appliances or clear aligners, you intercept these problems, interceptive treatment. As you alluded to with clear aligners, the data and the literature are incorrect. Same thing with phase one. And I've gone into that in different ways on this show and as guests on other people's shows. But the literature, when you look at what they were studying and doing and how they were studying it, is very, very flawed. And we know going all the way back to Bogue in 1913, and even Engel talked about this in the early 1900s, the concept of if you can get at these patients younger and develop the arches and grow the bone proactively, you have a less severe malocclusion to deal with later. And I always say to people, however you want to do it, the concept that we shouldn't be addressing malocclusion earlier and we should be waiting for the train wreck to happen when we could fix the track ahead of time and avoid a large part of that wreck. I had numerous patients that didn't even need a second phase. And if they do need a second phase, it is usually so straightforward and so easy and minimally invasive for these kids that I really do feel strongly that our profession has to get that way.
Yeah, it's just a matter of time. I think, Mike, honestly, with more and more people just exploring that for the benefit of the patient. One thing that intrigues me too, which I think we focus on the transverse a lot, which is appropriate, but class twos have a lot of dental compensation that happens over time from waiting,
Sure. Yep.
right? So, like, what if you intercept that dental compensation from happening? Then what happens to that mandible over time? Could you get more mandibular change? I don't know. I'd like to find out. It's like once,
McNamara talked about that
yeah,
exact thing. And show me a class 2 that doesn't have transverse deficiency in the maxillary arch, at least in the anterior middle thirds, right? I mean, we all know that class 2, that the anterior maxilla is like a V. Well, like you said, if you solve that first and develop that arch prior,
right.
are you going to be able to allow that patient to express more natural growth?
Yeah. It doesn't happen to everyone, but for some patients, you see that happen where they all of a sudden you expand them and boom, they came forward. And it's like, well, that's one thing off my checklist of problems I have to address in the future for them. So traditionally, we've dealt with these retrognathic patients with flared lower incisors. How do you get their mandible come forward? You have to extract them or do a ton of IPR in the lower. What if you're able
Mhm.
to actually prevent that from happening at a young age by treating them at the
Yes.
quote unquote right time? Again, that's a moving target for I think what we're discussing here. And so
Yep.
I do believe that's the next, I think, area of opportunity for the profession.
Yeah, I agree. And even if I found in my doing this, like I said, thousands of times, even if they aren't one that gets that spontaneous resolution of the class 2, all you're dealing with in phase 2 then is the class 2. You're not, like you just alluded to, you're not dealing with impacted canines and anterior crowding and proclined incisor. You've normalized all that other anatomy in phase 1, so you're just addressing the class 2, which give the average orthodontist a class 2 patient with broad arches and a not excessively deep bite and pretty well aligned teeth, that is not a very hard case
Mhm.
to treat. It's the ones that are full cusp class 2, 100% deep bite, moderate upper and lower crowding, impacted upper canines, and we spend so much energy trying to fix those. It's the analogy again to quote Peter Attia in his book where he talked about the eggs dropping off the person that was dropping the eggs off the roof. He'd always have this nightmare, and he's trying to catch all the eggs, and he's working so hard to catch the eggs that you don't think like, well, maybe I could actually go get this guy to stop throwing these eggs down here.
Right.
And that's where I feel our profession is. It's like we're so busy fixing teeth and straightening teeth that we don't say, even though, and I'll review this at the Winds of Change, which we're going to get to now, there's a preponderance of literature that talks about the science behind this. We just block that out and say, yeah, I can't really do that, but I'm just going to focus on tooth straightening. And I love hearing you say that, because you being such a visionary and great teacher and educator, to know that you're seeing that as well gives me a lot of hope that we're going to be able to really collectively start to push this message to our colleagues so they can start to understand it more.
Yeah, that's my next, I think, that's what's stimulating me at the moment is
Mhm.
trying to figure out how to do this in younger kids in the right way and trying to elaborate on that for people to just show the benefit. But again, everything is in the interest of the patient. It's not to just do it to do it. It's from things that my dad has taught me for many,
Mhm.
many years. He was teaching growth and development at Louisville. He was teaching functional matrix theory and going through
Melvin Moss. Yep.
Petrovic, Harvard, going through.
Hmm.
But from an educational standpoint, not saying that this is right, this is wrong. He would put the information out there and then he would show what he would do clinically, but you have to make it your own in terms of what you're going to take and what's in your belief system for that. But we have always done for the kids we did see phase 1 when it was appropriate, when there's a transverse issue, when we see that there's crowding in the dentition with regards to a risk of cuspid impaction, whatever the case may be, you see the mandibular arch compensation. So we've always been in favor of that. And with our TMD background, again, I know this is another contentious statement that malocclusions don't cause TMD, but there's hell are a variable in TMD, I'll tell you that much. And we see it day in, day out. It's just everyone's adaptability is different. And that's what we can't
Hmm.
predict, right? Everyone's adaptability is different. But the 100%, I think malocclusion can play a role in joints. And what are the most common malocclusions we see related with TMD are usually class 2 malocclusions, with narrow maxillas, deep bites. That's
Yep.
we routinely see it over and over and over again. So, we want to help avoid those type of things long term, give that patient the best opportunity of being healthy long term. Uh, and it starts from a growth and development standpoint.
Yep.
So, as you're alluding to, wins of change. That's a course we put on for educational purposes for all sorts of professionals. The angle I've always taken with, because I do with Dr. Movahead, who's my oral surgeon, is that we're always presenting on treating adult patients with sleep apnea and
Mhm.
how we're treatment planning them for success through orthodontic surgery or through MARPs, for example, or mandibular distraction, for example. I hate to let it get to that point. And
Yep.
so it's really bring individuals such as yourself that can really elaborate on how to address it at a young age and to
Mhm.
help really teach from a multidisciplinary perspective and a well-rounded perspective how we can help people.
Yeah. When you and Reza were talking about this, was it something that you felt that you were trying to build more awareness of this, or just create more of a commonplace for people who wanna learn about this, where we could all come together and idea share, a little bit of both? Kinda what's the overall vision of the Winds of Change?
To be honest with you, it was both. It was more of, I think, a lack of knowledge in the community. So
Mhm,
knew it was a topic that people were interested in. So we wanted to bring in oral mouthfunctional therapists, stroke doctors, sleep physicians, general
mhm,
dentists, orthodontists, oral surgeons. This is seen from a whole medical view, I should say. It's not
mhm,
just dentistry focused. We have half of the people speaking are MDs, right?
mhm,
So we're trying to truly just provide a comprehensive education on how we can approach this for our patients from young to old. And so selfishly, it's also for me to learn
mhm,
because I'm bringing people such as yourself into St. Louis so that we can educate our community because we all work together as well on what we can do for our patients to provide a service. And so it was both to address a need that people were asking for, people were always intrigued by it, but also to also selfishly, I just want to learn as much as they can about it. And so by bringing in people, it just makes that a little bit easier for us. There's a little bit of effort to put the meeting on, as you can imagine,
Sure. Oh,
but
yeah.
we love having the meeting. And it, then last year was one day only and we were sold out, meaning that we had max capacity. And by sold out, we didn't have any more tickets to provide. But this meeting is now a day and a half, and we are at max capacity as well. So the demand for the learn is definitely there. I think having excellent speakers is a huge part of the draw. So I appreciate
Mhm,
you coming to the event because I
mhm,
think that's a big part of it. And we hold it at the Ritz Carlton in St. Louis. So I think it's also a nice event to attend for
mhm.
people. It makes it for a nice setting and they tend to do a good job with setting things up. So I'm really looking forward to it. I appreciate your time and coming down there to help educate us.
Oh, it's my pleasure. I'm honored to be asked, and was excited that you invited me to do it. Humbled to be in with the group of people that's speaking, and really, really excited. Again, we hadn't spoken about this specifically at all, but you touched on, toward the later stages of this discussion, a lot of what I'm going to be focusing on when I speak, and starting to open people's minds to a different way to look at our patients at a younger age than just at their teeth. And that's really one of my biggest missions, is to help my colleagues see that we are so much more than two straighteners, and we can do so much more with our minds and our abilities to prevent a lot of these issues from happening. And we just have to be willing to understand the literature, understand the science, understand the biology, and then use our minds to expand our reality and broaden those horizons to do things that we are told a lot of times we can't do, but that are completely possible. So I've got some cool things lined up, and I'm really excited to be participating in it. So it's sold out. So it's nothing. It's closed at this point for registration.
So unfortunately, yes, at this point it's closed. We have the full capacity of the room. And so
That's
we have
great
like
though.
it's where you would hold a wedding. So we had a lecture hall previously that held like 100 people, and
Mhm.
now we have like the actual banquet hall, and we're at max capacity for it. So, we'll try to hold it again. I think we're not sure if we're going to do it every year or every other year, given the amount of effort that goes into it. But
Mhm.
we will have more in the future as well for this meeting. So it's gonna be a fun event. And selfishly, having you there for me to, which I do, I go and educate my referrals on when's the appropriate age to send for certain problems. Having another orthodontist there and having that message is important because we see still daily, we'll see patients coming in and say, "Oh, my dentist didn't say anything for my kid to come in." And lo and behold, you finally see the kid, and it's like, "Oh man, like I really wish I would have seen you 4 years ago or 5 years ago." So
Mhm.
having that message to the dentist, educate them on what problems to send when to the orthodontist, I think is super important. And so that's a huge part of, I think, having you there too, is just to educate the general dentist when is the right time to refer patients to an orthodontist.
Yeah, it is a big thing across our profession. Any orthodontists out there, even those who aren't super proactive on early treatment, knows that feeling of that patient walking in years later than you wanted to see them and saying, "Yeah, my dentist said everything was fine, and now we've got this mess." And on the airway side, a lot of these signs and symptoms of malocclusion that we see are comorbidities of sleep disordered breathing and issues with airway. And that's what I'll be talking a lot about as well, is how we can not only help them from an orthodontic standpoint, but from a quality of life and health standpoint. And we can really change the lives of these patients in ways that we don't even realize. And I didn't realize, honestly, Maz, until I started doing it and being a critical learner and always evaluating myself and my work. I started putting the pieces of the puzzle together and saying, oh my gosh, I'm not just addressing malocclusion. I'm changing this kid's life in a more profound way. And it was really that motivated me to go on this journey to teach it at the next level, because I couldn't let that, and much again, like your story with the liners, right? You had a bigger vision to try to educate where there was a void. And that's where I just really feel there's a void in our profession. That message needs to get out. So yeah, no, I'm so excited about it.
Can I share my screen real quick? Is that
Yeah,
possible?
please.
But just from what you were discussing about, educating and being able to help people. So this is my son, and I took this picture of him when he was uh, 7 years old. And unfortunately, the timing of this is around COVID. And so I saw this kid um, coming at the time of his delivery, and his mandible was so recessive that I was just freaked out. I'm a little bit embarrassed about this historically now, but I wheeled my wife and him to the ENT at the time because I was so concerned about his airway. He was like literally snoring when he was born.
Wow.
Um, and so the ENT had scoped him through his nose and said tonsils and adenoids were probably a little bit large, but it's probably more of a mandibular problem where he's just so retrognathic. But eventually, as he grows, and that the nostril will develop more, he'll be able to breathe more easily. So I'm like,
Mm,
okay, I'm going to keep an eye on this. And then cautiously watching him up until the age of 6, and he's just snoring his head off, and he's
mm,
open mouth breathing every single night.
mm,
So just again, having gone through being in practice with my father, going through the literature, understanding what sleep apnea can do to you as an adult, I really wanted to help my son. And lo and behold, going to the pediatrician, asking their opinion on things, they didn't recommend anything for him. Nothing.
I'll be talking about that too. Yep.
Nothing. Right? He may have gotten strep throat once or twice a year. He did get some ear infections repeatedly, but not enough to meet the insurance check mark for any type of treatment for him.
Mhm.
And so I just basically took matters in my own hands. And met with the ENT. Said, "We're going to take his tonsils adenoids out. I'm going to expand him." And
Mm,
literally, this is not a joke. This next picture is the day he came home from having
mm,
tonsils and adenoids removed. And he immediately started putting his hand under his chin for whatever reason like that. But this
mm,
is how he sleeps every night now. He sleeps
yeah.
so restful. I ended up expanding him because he had a very V-shaped neuromaxilla,
Mhm,
and he now has very restful sleep. But imagine the pull of the muscles, the influence on the face, the habitual development of things over time, if you have this kid versus the other kid. But I just those are the things I look out for. I'm sure you're going to touch on them in the long
oh,
term, but
yeah. Yeah.
this is so impactful for his life. Now I feel like he's a much healthier child because of what we did for him, which other people were not willing to do because their decisions aren't dictated all the time by science. They're also dictated by insurance or other variables that are to some extent outside of their control.
Mhm,
Uh, and so that stuff concerns me. I'll give you another example on something else here, and this is more personal thing, in that I have a family history of heart disease. My grandma and grandpa on my dad's side both went through open heart surgeries.
mm,
And dad has high cholesterol, has had stents in his heart. So I'm freaked out about my cardiovascular health. Okay.
mm,
And I go to a cardiologist. I'm 44 years old, and he has me on these statins. And I'm very blessed to have Dr. Sarver as a close friend and colleague, and I
mhm,
speak to him usually once every other week. We're on the phone, and so I share things with them. And I brought this up with him, and he says in his distinctive accent, "You need to be on Repatha." And I said, "What's Repatha?" And he goes through this story about how a cardiologist told him that this is what he needs to do because he didn't want his numbers to be good; he wanted them to be great
mm,
in terms of his LDL and HDL and so forth. So I went to my cardiologist and I said, "Why am I not on Repatha?"
mm.
And you know what his first answer to me was? "Because it's very expensive."
Oh,
And I said, I was like, "Well," I said, "I don't
wow. Think
care about the expense." I said, and my next question was, "You have a son, right?" And I knew he did. He said, "Yes, I do have a son." I said, "If he was me, would you want him on Repatha or would you want him on the statins?" He
mm,
said, "Repatha." I said, "Okay, well, we're going on Repatha." It's an injectable,
mhm,
right? My numbers have completely dropped and normalized, significantly better than any statin I was on. And I'm a
wow.
healthy guy. I work out every morning with my wife. I eat healthy, but this is a familial genetic issue,
Mhm,
right? these are the things that are wrong with healthcare, right?
Mhm.
So it's like at what point do we have to shake things up and take the bull by the horns and just do what we believe in and also do things based on, I think, not only clinical experience, but also the knowledge we do have, right?
Yeah.
Putting together the right pieces, having the right
Yeah.
team. So
Yeah. Yeah. I really appreciate you sharing that. The personal stories, both your son and yourself. Have you read Outlive by Peter Tia? Have you?
I have not.
You need to, because you're preaching from that book. That is no doubt. Yeah,
Yes.
Outlive. Yep, by Peter Tia. It is everything that you're speaking about right now. It's actually amazing that you saw all this and thought all this without having read the book, because when you read it, you're gonna be in lockstep with a lot of what he's saying. And that is my mission, to challenge those dogmas and to push the envelope. And we're gonna talk about that and really try to get people to see things a little differently, so that people like your son. What's your son's name?
Shia.
Shia, to get kids like Shia the help they need, because Shia is lucky that you're his dad, who has some knowledge and some connections in this area to get him the care that he needs. But there are a lot of little ones just like Shia out there who are being told by their pediatrician, orthodontist, general dentist, pediatric dentist, all the above, that there's nothing wrong, or they'll outgrow it, or not doing the appropriate diagnostics to figure it out, or saying it's really not that big of a deal. We didn't even get into, which I will be getting into in my lecture, the behavioral impacts, the psychosocial implications, the neurologic implications. There's just so much there. And it's so exciting to have someone like yourself on this journey and seeing this. And so many times it is when I coach and teach people on this, it is a family member or a child, especially, that starts to get them to think a little differently, for sure. They might be thinking things, but it's the final impetus to say, wait a minute, something else is going on here. And it's also awesome that you're opening it to non-orthodontists, because I love this profession. I wouldn't be where I am today without it. That being said, the traditional orthodontic dogmas that we started this whole thing talking about are very pervasive in this arena. And I call it the A word. They don't even want the airway word mentioned, right? I'll be touching on that too. I don't mind getting controversial. So I'll be talking a little bit about that as well, and talking about where that comes from, and some of the fallacies therein. But it's so important that we keep getting this message out. And the stories like you just told about Shia are what has motivated me to do what I'm doing today, because I saw it time and time again in my practice. And I feel it's my calling to go out and teach this on a grander scale. And I can teach basically any dentist to do what I did. It's someone has to get the message out there, because right now it's still not out there. So I really appreciate you creating the form of Winds of Change to allow this to be a multidisciplinary event, so we all can learn and continue to advance the profession in this way.
It's my pleasure. And I know that similar stories to you, I've had moms in tears about making the recommendation for tonsils and adenoids for their kids where no one else was making a recommendation. And they literally have a different child at home.
Yes.
That is a much healthier child that can actually thrive in school, that is starting to grow properly because they had failure to thrive because they had undiagnosed sleep apnea. We definitely, we involve the sleep physician, the ENTs all the time, but at the end of the
Yep.
day, the diagnosis is what's important and the impetus to actually recognize and send them to the right people.
I'll tell you, we didn't talk in depth. People are going to think we set this up. I swear we did not talk in depth about what my necessary lecture. When you reached out to me, you just said, I know you know the literature. I know you are big on the diagnostics and figuring out what this is. And that was pretty much the extent. There was probably a 60-second phone call that we had about it. So I'm really, really excited for this event. And if
Thank
I
you.
could be more excited after just having this conversation, I am, because this is what I love to do. So, well, I don't want to take any more of your time. You've been incredibly generous. How can people reach you or find out more about the Aligner Fellowship as well?
So my personal email, which I'm happy to give because I do give that out quite often, is moshirimaz@gmail.com. So last name, first name, no dots, hyphens.
Okay.
And the website for the Aligner Fellowship is alignerfellowship.com. And so our next session is starting in February. We usually go twice a year. I do want to say, by the way, Mike, it is free for all US and Canadian residents
Mm,
to take the fundamentals course. And it's also free for all full-time faculty to take the course. And so that's
mm.
just our way of giving back to the profession. And so if they want to reach out through the website, there's a support link, but it's basically support@alignerfellowship.com. If they have inquiries about that, we can then get them registered for the course.
Okay, great. Thank you.
Okay.
Well, Thank you again so much. Honestly, Maz, it's just been an absolute pleasure. And thank you for your contributions to this profession. And we didn't get as much into, maybe sometime if you're open to it down the road, I'll have you back and we'll talk a little bit more about the work-life balance and how you manage all you're doing, because that's a whole nother area. But I want to be respectful of your time, and you've given us a lot of that today. So, but just thanks for all you're doing for us. Keep it up and keep blazing this trail. We're
Yeah,
happy to
you as
follow on
well.
your coattails.
Thank you, sir. I appreciate your time as well.
All right, great. Thanks again.
Thank you.
Bye. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.